Welcome, everyone. In this presentation, we will discuss acute coronary syndromes, commonly known as ACS, from a clinical pharmacist perspective. We will integrate pathophysiology, diagnosis, reperfusion strategies, and evidence-based pharmacologic management according to contemporary guideline-directed care. The focus will be on understanding why ACS occurs, how it presents clinically, and how rapid intervention and optimal antithrombotic therapy improve patient outcomes. This section introduces the fundamental concepts of acute coronary syndromes. We will define ACS, review its major clinical categories, and understand the underlying pathophysiology that connects plaque rupture, thrombosis, and myocardial ischemia. Acute coronary syndromes represent a spectrum of conditions caused by acute myocardial ischemia, most commonly due to rupture of an atherosclerotic plaque followed by thrombus formation. ACS includes three major clinical entities: ST elevation myocardial infarction, or STEMI, non-ST elevation myocardial infarction, or NSTEMI, and unstable angina. The central pathophysiologic concept is that plaque rupture exposes thrombogenic material, leading to platelet activation and clot formation, which subsequently reduces coronary blood flow and causes myocardial ischemia. The pathophysiology of ACS begins with rupture or erosion of an unstable atherosclerotic plaque within a coronary artery. This exposes collagen and tissue factor, triggering platelet adhesion, activation, and aggregation. A thrombus then forms and partially or completely obstructs coronary blood flow. Partial occlusion generally leads to NSTEMI, or unstable angina, whereas complete coronary occlusion produces STEMI. The severity and duration of ischemia determine the degree of myocardial injury and clinical presentation. The three major forms of ACS. STEMI is characterized by complete coronary occlusion, resulting in ST segment elevation on ECG and significant myocardial necrosis with marked troponin elevation. NSTEMI involves partial coronary occlusion and myocardial injury, producing elevated troponin levels but without ST elevation. Unstable angina also involves partial obstruction. However, myocardial necrosis has not yet occurred, so cardiac biomarkers remain normal. Distinguishing these conditions is essential because management urgency and reperfusion strategies differ significantly. The classic presentation of ACS is chest pain, described as pressure, squeezing, or heaviness, often radiating to the arm, jaw, neck, or back. Patients may also experience dyspnea, diaphoresis, nausea, or vomiting due to sympathetic activation. However, atypical presentations are especially important in elderly patients, women, and individuals with diabetes. These patients may present primarily with fatigue, shortness of breath, or epigastric discomfort, rather than classic chest pain. Recognizing atypical symptoms is critical to avoid delayed diagnosis. The diagnosis of ACS relies on a combination of clinical presentation, electrocardiography, and cardiac biomarkers. An ECG should be obtained within 10 minutes of presentation because it rapidly identifies STEMI and guides immediate reperfusion decisions. ST segment elevation suggests acute transmural ischemia, while ST depression or T-wave inversion may indicate NSTEMI. Cardiac troponins are the most sensitive and specific biomarkers for myocardial injury and typically rise within 1 to 3 hours after infarction. Ultimately, ACS diagnosis integrates symptoms, ECG findings, and biomarker evidence. This section focuses on the early stabilization of patients with ACS. Immediate therapy aims to reduce myocardial oxygen demand, improve coronary perfusion, relieve symptoms, and prevent thrombus progression.
Initial management of ACS historically followed the MONA-B approach: aspirin, oxygen, nitroglycerin, morphine, and beta blockers. Aspirin remains the cornerstone of therapy because rapid platelet inhibition reduces mortality significantly. Oxygen is now recommended only for patients with hypoxemia, typically when oxygen saturation is below 90%. Nitroglycerin helps relieve ischemic chest pain by reducing preload and myocardial oxygen demand. Morphine may be used cautiously in persistent pain, but is no longer routinely encouraged because it can delay absorption of antiplatelet agents. Beta blockers reduce heart rate and myocardial oxygen demand, but should be avoided in patients with acute decompensated heart failure, shock, or severe bradycardia. Antithrombotic therapy is a central component of ACS management because thrombosis drives disease progression. Dual antiplatelet therapy consists of aspirin combined with a P2Y12 inhibitor such as clopidogrel, ticagrelor, or prasugrel. This combination reduces platelet aggregation and lowers the risk of recurrent ischemic events. Anticoagulants, such as unfractionated heparin, low molecular weight heparin, or bivaluridin, are also used to prevent clot propagation and further thrombin generation. Selection of therapy depends on bleeding risk, invasive strategy, and patient-specific factors. This section addresses reperfusion therapy, which is the most critical intervention in STEMI management. Rapid restoration of coronary blood flow limits myocardial necrosis and improves survival. In STEMI, the priority is immediate reperfusion because prolonged coronary occlusion leads to irreversible myocardial damage. Primary percutaneous coronary intervention, or PCI, is the preferred reperfusion strategy when it can be performed rapidly, ideally with a door-to-balloon time of 90 minutes or less. If PCI is unavailable within the recommended timeframe, fibrinolytic therapy using agents such as alteplase or tenecteplase should be administered as soon as possible, ideally within 30 minutes of hospital arrival. The key principle is that time equals myocardium. Therefore, rapid reperfusion is essential. Unlike STEMI, NSTEMI and unstable angina usually do not require immediate reperfusion because coronary occlusion is often partial rather than complete. Management focuses on antiplatelet therapy, anticoagulation, symptom control, and risk stratification. Patients with high-risk features such as recurrent ischemia, hemodynamic instability, dynamic ECG changes, or elevated biomarkers are candidates for an early invasive strategy involving coronary angiography and possible PCI. Risk stratification helps determine which NSTEMI or unstable angina patients are at greatest risk for death or recurrent myocardial infarction. This assessment guides decisions regarding conservative medical therapy versus early invasive intervention. High-risk patients benefit from earlier angiography and revascularization, while lower-risk patients may initially be managed medically with close monitoring. The TEMI and GRACE scores are commonly used risk assessment tools in NSTEMI and unstable angina. The TEMI score is simpler and designed for rapid bedside estimation using factors such as age, cardiac risk factors, ECG changes, and troponin elevation. The GRACE score is more comprehensive and predicts in-hospital and 6-month mortality by incorporating variables such as blood pressure, heart rate, renal function, and heart failure signs. Higher scores in either system indicate increased ischemic or mortality risk and support a more aggressive invasive strategy. This case demonstrates a lower risk NSTEMI presentation. The patient is hemodynamically stable, has only mild troponin elevation, no significant ECG changes, and no signs of heart failure or renal dysfunction. His TIMI and GRACE assessments categorize him as low risk. Therefore, initial management focuses on conservative medical therapy, including dual antiplatelet therapy, anticoagulation, statin therapy, and close monitoring, rather than urgent invasive intervention.
In this patient, the absence of hypotension, tachycardia, renal dysfunction, heart failure, or significant ECG abnormalities supports a low GRACE risk profile. This reinforces the decision to pursue conservative management initially, while continuing observation for any signs of clinical deterioration.
This case illustrates a high-risk NSTEMI presentation. The patient demonstrates persistent chest pain, hypotension, tachycardia, ST segment depression, renal dysfunction, pulmonary edema, and markedly elevated troponin levels. These findings indicate extensive ischemia and hemodynamic compromise. Her TIMI score is extremely high, strongly suggesting the need for aggressive management. The clinical findings indicate a very high GRACE risk profile because of hypotension, tachycardia, renal impairment, heart failure, and ECG changes. This patient requires an early invasive strategy with urgent coronary angiography, possible PCI, intensive antithrombotic therapy, and continuous monitoring in a higher acuity setting. This summary slide highlights the practical distinction between low-risk and high-risk NSTEMI patients. Stable vital signs, minimal troponin elevation, and absence of ECG changes generally support a conservative approach. In contrast, hemodynamic instability, dynamic ST changes, and significant biomarker elevation indicate high ischemic risk and favor early invasive management. After stabilization of the acute event, long-term secondary prevention becomes essential to reduce recurrent cardiovascular events and improve survival. Following ACS, patients require comprehensive secondary prevention therapy. Aspirin is generally continued lifelong, while a P2Y12 inhibitor is commonly maintained for up to 12 months as part of dual antiplatelet therapy. High-intensity statins stabilize plaques and reduce future cardiovascular risk. Beta blockers decrease myocardial oxygen demand and reduce arrhythmia risk, while ACE inhibitors or ARBs improve remodeling and cardiovascular outcomes, particularly in patients with reduced ejection fraction, hypertension, or diabetes. ACS can lead to multiple life-threatening complications. Arrhythmias are the most common early cause of death after myocardial infarction due to electrical instability in ischemic myocardium. Other complications include heart failure, cardiogenic shock, and mechanical complications such as papillary muscle rupture or ventricular septal rupture. Early recognition and management of these complications are critical to improving patient survival. To summarize, patients presenting with chest pain should receive an ECG within 10 minutes. ST segment elevation identifies STEMI and requires immediate reperfusion with PCI whenever possible. In the absence of ST elevation, troponin levels and risk stratification guide management decisions. Regardless of ACS subtype, antiplatelet therapy and anticoagulation remain foundational treatments. Rapid diagnosis, timely reperfusion, and evidence-based pharmacotherapy are essential for optimizing outcomes in ACS patients.